Thanks, Gene. Thanks, Ruben. It's such a pleasure to be here. It's my first time to Arizona, first time to this marvelous conference. We have patient conferences in Germany, and I already got lots of ideas. So thanks a lot. I learned that you people are early risers, so tip my hat. This reminds me of our ASH meeting when the typical breakfast meeting for the Europeans is at 6. So we're proud about that. But the reason for that is that we're all jet lagged, so we can't sleep anymore. So that's why we rise early. The second thing, I hope, by the way, that bald joke was not on my behalf. I heard that you guys have humor, which is fantastic. And also, I learned that you guys participate, right? The audience has to participate. So I would like to do one experiment with you. Can we, on the count of 3, all pronounce my hometown, which is displayed here, which is called Aachen. So maybe you can do that. Do some German. 1, 2, 3, Aachen. Oh, wonderful. Gesundheit. So my talk is on inflammation in MPNs. And can I ask you, who has had inflammation before in the past? Anyone? I think we all have. So is inflammation bad? Yes and no. I would say no, because we need inflamed tissues, we need inflamed cells to fight infections. But it can be bad if it's chronic inflammation, and Angela has nicely shown this morning. So we're talking about MPNs, of course, and they're a part of this larger list of various myeloid neoplasms. And inflammation is part of, I would say, all of these. This is recent evidence that we've gathered, especially in the MPNs, the Philadelphia positive MPNs and the Philadelphia negative MPNs. So if we look at cancer in general, there are certain hallmarks that have been identified for a cancer to be a successful cancer. This is the view of the cancer cells, of course. And you can see here, I don't know, can you see the cursor? So that tumor-promoting inflammation is one of the hallmarks of cancer. And MPNs are very particular in that sense because the clonal cancer cells themselves are inflammatory cells. So it's not a miracle or unexpected that inflammation plays a large role in MPN pathogenesis. And maybe it's an angle that we can tackle in our patients. So I would like to share with you some of my personal thoughts on MPN pathogenesis and the role of inflammation. So how does an MPN start? And we've heard from Jody yesterday very nicely what's all known about when this may start, when the JAK2 mutation emerges, and then much later in life we can see overt disease unfoiling. And so here I've just drafted a small sketch of a normal hematopoietic stem cell acquiring this JAK mutation, as you can see here. And then this JAK2 mutant stem cell, and we believe it's really one stem cell that it all starts with, will go on to become another stem cell, which we call self-renewal. But it will also go on to differentiate into daughter cells. And there are stepwise differentiations and amplifications of these progenitor cells, as we call them. And then eventually, this will lead to mature cells in the blood and the bone marrow that exert the function to fight infections, to produce enough red blood cells and also platelets. But these cells then are, to a large part, JAK2 mutant positive. So where does the inflammation come in? Probably at the very first stage already. So these stem cells are known to produce inflammatory cytokines. So these are molecules that affect other cells in an inflammatory manner. And then as you can see here, with increasing differentiation, the amount of these inflammatory cytokines is increased. So we will then not only have the clone, the JAK2 positive clone, as we call these cells, but also the normal cells in the bone marrow and the other organs are affected by these JAK2 positive cells to become inflammatory. And then not only the blood cells are inflamed, but also the stromal cells that line the endothelium in the bone marrow, so that the vessels, or line the bone. And all of these cells can become inflammatory, and then eventually that can lead to a suppression of normal hematopoiesis, so normal blood cell development, and also normal stroma cell function. And that means that it's a vicious circle with more and more of these inflammatory cells. The normal cells may be suppressed. So it's a good idea to understand this concept and also think about where can we intervene. So I would like to go through this list a little bit more in more detail. So as we said, this hematopoietic stem cell in the bone marrow acquires a somatic mutation. It can be in the JAK2 gene, but it can also be in the calreticulin gene or MPL, and all of these three are called driver mutations. So this has been described to occur very early in life, for example, in utero or early childhood. And the JAK2 mutation has been shown to induce cycling of these stem cells. Cycling means they will proliferate more. And where does this come from? So we know that early immature cells in the blood and bone marrow from MPN patients express inflammatory cytokines. So this is proof for the concept that this occurs very early on. So here you can see something that's called target-seq. So it's a methodology where you can look at many genes at the same time. And if you then look for the grouping of these genes, as we heard in Angela's talk, then you see some certain cytokine pathways, inflammatory pathways pop up. This is TNF-alpha, for example, interleukin-6, and the interferon pathway. Yes, interferon is also an inflammatory cytokine. We all have it. We produce it when we get a virus infection. But apparently, as Jean-Jacques told us, in certain diseases like PV or other MPNs, we may need exogenous help through administration of more interferon. So we can see inflammatory pathways in these cells from patients, and this is another study that we did from our patients. You can see that in comparison with healthy donors, healthy persons, patients with these different MPN diseases have increased levels of a lot of inflammatory cytokines. And here I would like you to focus on these two, S100A8 and A9, because they will become more important later on during the talk. So I told you that these mutant stem cells divide, and they can divide symmetrically, meaning that all of the daughter cells will again become stem cells. This is rather rare in this disease. You can have that in very aggressive cancers, but typically they divide asymmetrically, meaning that they give rise to the daughter cell that becomes another stem cell, and asymmetric division means that the other cell will be more differentiated. Is there some evidence that that happens? Yes. We know now that MPN-derived stem cells are skewed towards megakaryocytes. And Jody showed you some pictures of a megakaryocyte. So these are the big cells in the bone marrow, the biggest cells we have there that shed the platelets. So stem cells in the bone marrow of patients with MPNs are skewed towards megakaryocytes. And maybe that's one reason why we see increased megakaryocytes and increased platelets in a lot of MPN diseases. And here we can see that certain genes are implicated in this axis. So one is called platelet factor 4. We know from experimental studies in mice that mice that don't carry this PF4 gene, they have much less of these megakaryocytes when they when JAK2 is acquired. So meaning that we have certain genes that produce or that have an important role in the production of platelets. Another nice model that we now have is the so-called induced pluripotent stem cell model, iPSCs. What are these? So these are stem cells that we can generate in vitro from patients with, for example, CALR mutations or a JAK mutation. And then these cells are taken from the peripheral blood. They're de-differentiated into stem cells, as we say, and then we can again differentiate those into blood cells or into vessel cells or into other stromal cells. And by that, we can nicely analyze in vitro human cells that recapitulate the features of the disease, at least in part. And we've seen using this model that, again, these MPN-derived iPSCs are skewed towards megakaryocytes, so they produce more megakaryocytes than normal cells, and they become independent of exogenous signals. You've heard about TPO yesterday. TPO is like the EPO hormone for the platelets, and cells that express the CALR mutation or the JAK mutation become independent of TPO stimulation. So they can grow even without the food. And so this is a very important concept because it will not help to shut down TPO signaling in these patients because the cells are not dependent on it anymore. And we can nicely model this with this technology. So then we've seen that progenitors may be skewed towards megakaryocytes, but then also the whole picture is very complex because we have so many different blood cells, and all of these can carry the JAK mutation, for example. So the JAK mutation has been shown to occur in neutrophil granulocytes or monocytes or macrophages. So these are the typical defending cells. They have been shown to occur in platelets, but also in monocytes and even in lymphocytes. And also there's evidence that endothelial cells, so the blood vessel lining cells, express or may express the JAK mutation. So this has been shown at the DNA level. We don't know whether this also means that they produce protein, but it's very important to know that it's not only one cell that is positive, but it's many cells that are positive for the driver mutation. And why am I telling this? It's because the endothelium is really important in an inflammatory reaction. We know this from the COVID pandemic, where it was clear that many of the patients got so sick, not only because the virus was affecting the immune system, but also because it affected the endothelial cells in the lungs. So endothelial cells can be very important for inflammation, and in MPN, that's also true. On the other hand, conversely, bone marrow stromal cells, so these are the architectural cells that make up the bone and the bone lining, those cells have consistently been negative for the JAK mutation. So these cells, if we model our disease in vitro, we will select stromal cells that do not harbor the mutation, and then blood cells and endothelial cells can be used that harbor the mutation. And this is work by some of my colleagues, Madeleine Caduc and Marcelo de Toledo in Aachen, who have designed a complex system of putting all of these inflammatory cells together in the dish, looking at stromal cells, endothelial cells, and then various blood cells. And the interesting thing is that we can determine the mutation and determine whether, or we can define whether the mutation is present in one particular cell type or not. And then we can look at what happens. And this is a busy slide, but I just want to alert you to two things. One is that MPN signatures such as JAK-STAT signaling or fibrosis are seen in these 3D bone marrow niches in the dish. And also, we've looked at the effects of interferon in the dish, and it nicely reverts some of the hypoxic and profibrotic conditions in vitro. And then also in vivo, we saw that this is the case in mice. So the addition to interferon can revert the fibrosis in the bone marrow of these mice. And you've heard from Jean-Jacques Piladjian that indeed there's data from New York and other centers that if we use interferon very early on during the disease, then in the long term, decades, 10, 20 years, 30 years, we are seeing less fibrosis with interferon than if we don't use it. So these are some in vitro experiments that support this concept. So the next thing that happens then, if we go from the stem cell to the more differentiated cell, is that these cells may become a clone, right? So if the cells proliferate more and more, at some point we can see this clone in the peripheral blood or in the bone marrow. And importantly, at that stage, and I think Angela has shown it, this CHIP stage, clonal hematopoiesis, at that stage, these persons do not have overt disease. So they don't have an MPN, but they have these JAK2 mutant cells. And it's been shown that at that stage already, these few cells locally produce cytokines. So there's local inflammation, very small foci in the bone marrow. And then this is showing this. So if we look at single cells, we can see that, for example, in the stem cell compartment, we see an overproduction of certain cytokines when they are positive for the JAK mutation. And also, importantly, it's not just that these cytokines are there and they don't do anything, but if you inhibit these cytokines with antibodies, then you can see that these stem cells proliferate less. So they have a reduced turnover if you inhibit some of these cytokines. Why do we think about and talk about CHIP, clonal hematopoiesis? As we just heard, most of the patients that have CHIP will never develop disease. And this is work by the Danish group that was also cited yesterday. Hans Hasselbalch and his colleagues showed that in those patients where the allele burden, the VAF, remains the same, very, very low VAF, all this remains the same over years, they will not go on and develop any MPN. However, the ones that show an increase in their slope, they may develop an MPN, and entirely there's a risk of roughly 300 to 400-fold that someone with this JAK2 chip may eventually go on to develop an MPN. This sounds like a huge risk, but on the other hand, since these are so rare diseases, as you all know, this is a small risk even then. But this may in the future mean that these CHIP patients or CHIP persons, they should be followed in a CHIP clinic. This is increasingly done worldwide because we want to see whether they belong to this group with the slope, elevated slope, or whether they remain the same. So then, once we have a considerable amount of peripheral blood cells that produce these cytokines, then this may eventually cause an MPN disease, and which we then see as symptomatic. For example, patients may have night sweats, weight loss, fatigue, pruritus, and so on. All of the symptoms we've discussed yesterday, really a multitude of symptoms. We can then see the blood cells rise, so thrombocytes, thrombocytosis, erythrocytosis, leukocytosis, and then also we can then see that the cardiovascular complications may increase, meaning thrombosis, heart attack, stroke, or bleeding. So this really occurs very, very late in the disease or in the process, as we heard by Jody yesterday. This may depend on how fit one clone is. If there's a very fit clone which has lots of impact, lots of proliferative potential, we may see the disease earlier than in someone who really has a very slowly proliferating clone. I want to just mention some specific cytokines here without going into too much detail, but there's good evidence that several cytokines are more important than others. For example, as you can see here, IL-1 beta, interleukin-1 beta, which is produced by leukocytes. That's why we call them interleukins. It's required for an MPN, JAK2 MPN in mice. And this is nicely shown here because if mice don't have this gene, they cannot produce interleukin-1 beta here. And then, as you can see here, they will have much less thrombocytosis, so the platelets are lower than in those mice that have the gene. And also neutrophils will be lower, so meaning the disease is not completely gone, but it's much milder in these mice if they don't produce IL-1 beta, at least showing us that in mice IL-1 beta is an important cytokine and has a role in disease development. And this is also true for fibrosis. So you can see here, you can see less gray here. The gray would be the fibers, as you can see on the left. So if they have interleukin-1, there's more fibers than in those mice that don't have any interleukin-1 anymore. And also they have smaller spleens. So this again shows us that interleukin-1 is an important player here. And there's a second report that shows exactly the same thing. And both groups have gone on to try in these mice to give these mice interleukin-1 antibodies, so very specific treatment, and they could show that the disease was much milder in those mice receiving the antibodies. So that could be something for the future to look at interleukin-1 antibodies. Of note, interferon alpha also decreases interleukin-1. So maybe this is one reason why interferon may act in that sense that it decreases inflammation in MPN in the long run. So here you can see that certain cytokines are produced by the MPN cell, for example, interleukin-1 beta, IL-6, IL-8, and then they will inflame the normal cells, as you can see here. This is a complex slide, just tells you that many cytokines have been looked at in patients with MPNs, and they have been linked to certain symptoms and also in some cases red blood cell transfusion dependency, and even survival. So there is some evidence that if you have reduced, elevated interleukin 1, interleukin 8 and interleukin 2 receptor in the blood, one of each or both, if they're elevated, then the survival may be poorer than if you don't have this. Of course, as we said yesterday, survival curves are very problematic quite often because they're historic data. These patients haven't been treated with the drugs that we have today. So it's really just important to look at this as a concept of what these cytokines can do. Here I'm showing that interleukin 6 may be elevated. And this is important because we know that we have drugs that counteract interleukin 6. One of it is are the JAK inhibitors. For example, ruxolitinib. Here you can see one of the studies showing that the spleen length is nicely reduced by ruxolitinib. And here in green, you can see all of the cytokines that are reduced during ruxolitinib treatment. And you can see that there's only very few of these genes that are red, so meaning they go up during ruxolitinib treatment, while all of these major inflammatory cytokines are reduced. So that's a good thing, right? JAK inhibitors are anti-inflammatory drugs. Interestingly, leptin is going up, and we know that some patients taking ruxolitinib have a very much increased appetite. So it's important to note that. So we've had patients gaining 20 to 25 kilos during ruxolitinib treatment. And I had this one young patient who told me she works at a bakery and there's so much sweet stuff around. She can't really stop it, but as we educated her and discussed this, that her leptin levels may be up, that's an explanation, then it was much easier for her to pay attention to this. So there is a good explanation for this. Also, as I said before, it's important to know whether these cytokines are just there and passenger effects and they don't act on the disease, or whether they're implicated in the disease. And what you can see here is that they're really implicated in the disease because we find a very nice correlation between cytokine reduction during ruxolitinib treatment and the spleen response. So the spleen response was always best in those patients here with, you can see the arrows, that also showed the most decrease, the most pronounced decrease of these cytokines. So cytokines are an important factor in the disease, and JAK inhibitors may, at least in part, act through inhibition of these cytokines. So then I told you that these JAK2 mutant cells in the bone marrow and the blood, they may affect non-clonal cells, so just normal cells. So this is a very elegant study where these colleagues took cells from an MPN mouse, as I call it here, and a normal mouse, and they were transplanted into another mouse. And then they measured cytokines in these different populations. And the basic idea here is that not only in the transplanted mice, not only the JAK2 positive cells produced a lot of these cytokines, but also the JAK2 negative bystander cells. And that tells us that we cannot only focus on the JAK2 positive cells, but we also need to take into account all of the cells that may be part of that inflammatory response. And so eventually disease progression towards fibrosis and even sometimes acute leukemia can happen. So we would like to act early and try to prevent inflammation. And here I would like to remind you of of the two cytokines that I initially alluded to, S100A8 and A9. So this is Rebecca Schneider, a colleague of mine from Aachen, who showed that with a specific drug called tesquinimod, she was able, or they were able to pretty much normalize the disease in JAK2 diseased mice. So here you can see that the spleen size is normal, and the degree of fibrosis is really much, much improved with this oral treatment of tesquinimod. And we're currently starting a clinical trial, or it has just started, together with the colleagues in Rotterdam and my colleague Martina Krüsand in Aachen, who showed that this tesquinimod is now applied to patients as a tablet. And the good thing is that there have already been trials done in other diseases. For example, it had been used in prostate cancer, where it was well tolerated. So now the hope is that it's also tolerated well in MPN patients, and that it may decrease inflammation in these patients. So with that, I would like to summarize that inflammation is important in MPNs, both to understand the pathogenesis of the disease. Then in the diagnosis, there are many inflammatory markers that we can look at in the peripheral blood and use for diagnosis. And then, as I said, JAK inhibitors, interferon alpha, other agents have inflammatory properties. So this lets us be hopeful for the future. And then, as you saw also yesterday, there are really a lot of novel drugs that we can use for the treatment of MPNs, including anti-inflammatory drugs. So with that, I would like to acknowledge everyone in Aachen and our collaborators and throughout the world and our funding agencies. And here's a picture of the Aachen Cathedral. If you ever get a chance to get over there, this was built in the 1800s, and the Emperor Charles the Great was crowned here. So thanks a lot, and happy to take questions.